Perfect. Thank you and good afternoon. My name is Nikula from Finland, but I've been working here in Stockholm at Astrid Lindgren's Children's Hospital in the emergency department for about 7 years, 2010 to 2017. And all the studies have been done here at the Astrid Lindgren's Children's Hospital in the emergency department, but in collaboration with the University of Helsinki as well. And what we're talking about is intranasal dexmedetomidine and its use for procedural sedation and analgesia in pediatric emergency department. We aimed to evaluate the analgesic and sedative effects of intranasal dexmedetomidine during painful procedures in children. And we especially wanted to determine if intranasal dexmedetomidine could be used as an alternative for the other medications that we use for procedural sedation. And then we also wanted to evaluate the influence of procedural sedation on children's behavior. So what we did was 3 studies actually, of which 2 were randomized clinical trials described here. We compared intranasal dexmedetomidine with intranasal esketamine in the study 1 and with the nitrous oxide in study 2. And these esketamine and nitrous oxide were the medications that we used in daily basis at the Astrid Lindgren's Children's Pediatric Emergency Department at that point. They were both prospective studies. The first one was a superiority study where we hypothesized that dexmedetomidine is superior to intranasal esketamine. It was a double-blinded study. And the other one was a non-inferiority study where we wanted to show that intranasal dexmedetomidine is not inferior to nitrous oxide. It was obviously an open-label study. The patient groups 1 to 3 years old in the study 1. Healthy children coming to the emergency department because of a minor trauma and needed a procedure for that and needed sedation in order to do the procedure. And the other study was 3 to 15 years old children with fracture or luxation as well coming to our emergency department in requiring procedural sedation for the treatment. The primary outcome was the highest level of pain during the procedure, and that was measured with FLACC, one of the validated pain scales for children. It's an observational pain scale, and the assessment was done by the trial physicians, which was myself and a colleague from our department. The secondary outcome measures were sedation depth, parent perceptions, also in the older group, children's perceptions, and ED physicians' feasibility of the procedure. And then we did a follow-up study for the children who participated in study 2. We interviewed their parents with a semi-structured interview over telephone 4 weeks after the procedure, and there we aimed to see the possible behavioral changes the procedural sedation had on the children. This is just a list of our participants, but mainly you can see that the groups were similar within the study. We had a little bit more boys than girls, which is expected. Boys tend to have more traumas than girls do, and otherwise the groups were similar. So going to our results and for the studies 1 and 2, the clinical trials, and I do draw them together because our aim was actually dexmedetomidine. So even though they're 2 separate studies, I'm showing the results all together. Unfortunately for the younger children, the study 1, we did not reach the sample size, which was 52 patients. Within a little bit over 2 years, we started the study 2017 and finished 2020. We actually only reached 30 patients in that group. So we failed to show the superiority of dexmedetomidine to IN-esketamine. However, if you look at the part above, you can see that we did have lower pain scores on children receiving intranasal dexmedetomidine, but the statistical significance is not there. But instead, for the study 2 with the older children, we did show dexmedetomidine not being inferior to nitrous oxide when we consider pain. So this was our main result. For the secondary outcome measures, as I said, sedation, death, the perceptions by the child and or parent, and the feasibility of how the procedure, how easy the procedure was done by the ED physician. Looking at the sedation depth, the first one is again the study 1 with younger children. As said, we did not have enough patients to show the difference. When looking at sedation, we did have a little bit deeper sedation level with dexmedetomidine than with esketamine, but no statistical significance there. And the comparison to nitrous oxide, we can see that with nitrous oxide, all the patients reached to level 2 sedation, but with dexmedetomidine, not all reached it. However, the couple that did not reach level 2, they were cooperative for us to actually manage the procedure. And we had a couple with a deeper sedation level. Coming to the perceptions, here with parental satisfaction, we gave them a questionnaire directly after the PSA to fill in, just a couple of short questions. And we can generally see that the parents were really satisfied with the procedure and the sedation. And generally, it was fairly easy for the physicians to actually do the procedures, but no statistical difference there. We did see a statistical difference in the pain assessed by either the child himself or the parent in the study group of nitrous oxide and dexmedetomidine. The interesting part is that actually looking at the assessment by a physician, we had same pain level in both groups, but the children and parents actually graded higher pain scores with intranasal dexmedetomidine than with nitrous oxide. But if we look at the next rows here, we still can see that they would accept the same method for a procedural sedation in the future as well. So what do we actually think about this is a big question, but we did see that they assessed their pain lower with nitrous oxide than with dexmedetomidine. Adverse event was not our outcome measure, obviously, because this was not a safety study. We did not have enough patients to say this is safe, but we did look adverse events, which we did not really have that many. We had no cardiorespiratory adverse events that required some intervention from us. The most adverse events we had with nitrous oxide, and mainly with well-known nausea and vomiting, but also hallucinations. But none of these, well, actually the nausea and vomiting, we needed most of them, or all of them, we needed to stop. With some of them, they got ondansetron, and then we were able to pursue again, but not with all. But otherwise, no adverse events that required us stopping our treatment. And then finally, to the third study. This has not been published yet, looking at the behavioral changes in children. But we interviewed 148 parents after a month of the procedure, and we found 4.5%, that was 8 children with negative behavioral changes. They were basically that they were a little bit more afraid of doing things than before. One could ask, they have a cast in their arm. Does that play a part? Some parents said that he doesn't want to climb in the tree because he's afraid of hurting his arm. Okay. Well, anyway, that's hard to say. But the positive side was we had 5 children, over 3%, who actually had a positive effect of the ball. They were less afraid of doctors. 2 children actually had started playing a doctor, which they hadn't done before. So I think that is something really interesting and nice to see. So to conclude, we did find that intranasal dexmedetomidine does provide adequate analgesia and sedation for the common painful procedures that we do in pediatric emergency departments, and that absolutely intranasal dexmedetomidine can be considered as an alternative for those intranasal esketamine and nitrous oxide, for example, and possibly other medications as well. I wish to thank you, my supervisors for my PhD, as well as the whole Astrid Lindgren's Children's Hospital's Emergency Department, a couple of colleagues sitting here as well, and all the nurses, everyone who was actually helping with this. And here are our publications so far. Thank you.
So thank you very much. Questions from the audience? I have 1 or 2 as well, but we might take them during coffee. So any questions? Yeah, over there. Just give me 1 second.
Hi, I'm Aaron, also from Astrid Lindgren. You designed this study almost 10 years ago, and that was a little bit different, like dexmedetomidine was relatively new and so on. If you had designed this study today, would you do it the same way or would you do it differently?
There are a lot of things I would do differently, but I'm not going to go into them. I think I still think there's not a lot published on intranasal dexmedetomidine, which is one of the reasons it's not used as much. Actually, these are, I think, when we add these up, we are up to about 10 publications on it. We do have a lot of departments in the Nordic countries, elsewhere as well, where we're not as well equipped as you are for procedural sedation and analgesia, where we actually need really safe options. So I think it's still necessary for today. So yeah, I think I would still want to see more studies about this. It has its pros and cons, obviously, but yeah, I think I would still do it, but there are a lot of small things I would do differently.
So thank you. More maybe of an implementation question on my part, because as you probably all are familiar with, there seems to be this narrative that, and contrary to the literature, like your own studies and several others, that dexmedetomidine is not really a good drug if you have ever so the slightest bit of pain related to the procedure. On the other hand, the literature speaks to the fact that it could be probably used at least in moderately painful procedures as well. How do you think we can overcome that barrier? Because I keep hearing this over and over again in different places where people start implementing sedation in children and they say, well, we won't do dexmedetomidine because it's not good for painful things.
Yeah. It depends what you're doing, obviously. But we did fracture reduction. But what I did not tell here, because I didn't go through the whole procedure, what we do is that they all received paracetamol 1.5 hours before, and obviously all had local anesthesia as well. So the combination of that with pain medication and anesthesia, local anesthesia, is obviously what you most likely need. The issue with, especially with pediatric, with children, when you do procedural sedation, you need to consider different parts of it. So children can't always say what's pain, what am I afraid of, and all that, and their anxiety levels. So it's kind of a mixture of all. But yes, I don't know. I would say no if you want to do a fracture reduction just with dexmedetomidine. I would stop you. But with the local anesthesia, it seems to be working well.
Thank you. And so I think there's time for one last question for Anna, if somebody... Yep.
My name is Albano. I'm working on Astrid Lindgren too. My question is about the dosage. How did you choose the doses for esketamine and dexmedetomidine in your study?
Yeah, so esketamine dose was what we used at that point, and it obviously comes up to that also with the what the drug is, how big of a dose you can give intranasally at one time. So you can obviously build it up if you give several doses, but so that was what we used. And for dexmedetomidine, 2 micrograms per kilo was what was used at that point as well. Now there are studies up to 4 micrograms per kilo, but there are studies that show that 4 you might have bigger risk for adverse events, but it might be 3 micrograms per kilo, which actually could be the most favorable dose. But I think you also need to consider what you are doing, because when you go up with the dose, you're most likely going to have a longer time as well for the sedation. So I think 2 to 3 micrograms per kilo would probably be the most preferable, and then think what you're actually doing, what you need. But I would not go 4 or above.
Thank you very much, Anna.
Thank you.